Okay, I'm sure before we go into the details of coagulation disorders, I would like to recapitulate the coagulation pathways. I'm sure you're all familiar with these two pathways, the intrinsic and the extrinsic pathway. The extrinsic pathway involves mainly the factor 7 and the tissue factor, which is released by tissue damage. And the intrinsic pathway involves factor 8, 9, 11, 12. And then there's the common pathway, which involves factor 2, 5, and 10. 2 meaning prothrombin, 1 is fibrinogen. So 1, 2, 5, 10 are common. 7 is the extrinsic pathway, and 8, 9, 11, 12 involves the intrinsic pathway. You kind of need to remember these for future reference. Okay, so now we'll move on to the next thing. Okay, so just to remind you that the test for the extrinsic pathway, whether the extrinsic pathway of coagulation is intact, we look at the prothrombin time. Okay, and to see if the intrinsic pathway is okay, we'll look at the activated partial thromboplastin 39. The prothrombin time is about 12 seconds. So you need to know the normal levels of these. Let's discuss a few common questions asked from prothrombin time and APTT. As I told you, prothrombin time is a measure of the function of the extrinsic pathway. The factors involved in the extrinsic pathway are 2, 5, 7, and 10, mainly 7. So these are vitamin K dependent clotting factors. Okay. So deficiency of any of these factors or deficiency of vitamin K, for example, in liver disease, would increase the prothrombin time. Warfarin is an anticoagulant, as you know. It acts through the extrinsic pathway. So you have prothrombin time to measure following warfarin therapy. As I said, liver function. These are the 3 important uses of the prothrombin time. So this is pretty important. Liver disease, vitamin K deficiency, and follow-up after using warfarin. So these are the important uses of prothrombin time. Okay. We know about heparin. Heparin does not affect prothrombin time because it acts through the intrinsic pathway. So what about the activated partial thromboplastin time? Where is it used commonly? It is used commonly in 3 conditions. Basically, as I said, following heparin therapy, we monitor the APTT to diagnose coagulation disorders like hemophilia and von Willebrand's disease. As we know, these are diseases due to deficiency of factor 8, which we saw that it is involved in the intrinsic pathway. So APTT is used to monitor treatment with heparin and to diagnose diseases like hemophilia, von Willebrand disease. So this is the important use. So let us look at this table where we use a combination of prothrombin time and APTT to diagnose different conditions. Okay, so in your exam, you will have different scenarios where you will have lab tests of prothrombin time and APTT given. So you'll have to interpret your case accordingly. For example, if a patient has a prolonged prothrombin time but a normal APTT, as we saw, liver disease, warfarin therapy, decreased vitamin K, these are the conditions causing this combination of results. A normal prothrombin time, prolonged APTT. You will see that in von Willebrand disease, in hemophilia, in heparin therapy. If both are prolonged, very important, DIC. We'll be going through that a little later. Disseminated intravascular coagulation. Both PT and APTT will be prolonged. Okay, so keep this in mind as we go forward. Okay, this is another way of looking at the combination of lab results. What do we get in warfarin therapy? I'll put the question in another way. We will get a raised prothrombin time. APTT is usually not raised unless it's very severe or prolonged case. So you'll just remember a normal APTT. Platelet count will be normal and the bleeding time will be normal. In DIC, as I told you, the prothrombin time will be raised, APTT will be raised, the platelets will decrease, bleeding time will be raised. We'll study about DIC later on. What about in the coagulation disorders, hemophilia, von Willebrand disease? Both of them, the prothrombin time will be normal because they don't involve the extrinsic pathway. The APTT will be highly raised in hemophilia, just mildly raised in von Willebrand, may even be normal. Platelets will be normal. Bleeding time will be raised in von Willebrands. Okay. So we will need this table later on as we move forward. So you have cases in your exam with these combination of lab results. You'll need to interpret them as to solve your answers. Okay, now let's go through the individual conditions. Hemophilia, you're all familiar with. It's a coagulation disorder where there is deficiency of factor 8 in most cases and also factor 9 in 20% cases. So you have two types of hemophilia, hemophilia A and hemophilia B, due to factor 8 and factor 9 deficiency. Okay. So the important point, these are X-linked recessive disorders. X-linked recessive disorders. Okay. So basically, males will be sufferers and females will be carriers. You won't have, it's very unusual to have a female suffering from hemophilia. And as I told you, it's due to factor 8 and 9 deficiency, which are clotting factors involved in the intrinsic pathway, intrinsic coagulation pathway. Okay. What is the common presentation? You will usually get a scenario where a child has bled after a mild injury. They will be bleeding in the joints or the muscles, or following dental extraction, there will be profuse bleeding, or after surgery, there will be profuse bleeding. So these are the scenarios you will get in the exam, which will point towards a diagnosis of hemophilia. So what are the lab results that we will get in hemophilia? I already gone through them. I'll just summarize for you. You will get a prolonged APTT, a grossly prolonged APTT. The bleeding time and prothrombin times will be normal. And if you do, after that, if you do a factor assay, factor 8 or 9 levels will be low, which will point to the diagnosis. You treat hemophilia with factor 8 or 9 replacement. That is the definitive treatment. Okay. So look for a young patient presenting with bleeding in the joints or muscles with a prolonged APTT, which will point to diagnosis of hemophilia. Von Willebrand disease is another coagulation defect. This is due to von Willebrand factor deficiency. Now, where do we need von Willebrand factor for? Let me show you the normal function of von Willebrand factor. This is needed for platelet adhesion to vessels after an injury for hemostasis. So they are needed for platelet adhesion. They help the platelets to bind to the injured endothelium. They also carry clotting factor 8. So von Willebrand factor has important functions. So if this factor is deficient, there will be prolonged bleeding. This is the most common inherited bleeding disorder. It's autosomal dominant. So males and females are equally affected. So what is the important function of von Willebrand factor? This is asked sometimes. It binds to collagen, subendothelial collagen, and to GP1B receptors on the platelets, helping in platelet adhesion. So this is an important function you need to know. This is sometimes asked in the exam. It also protects factor 8 from breaking down. So a deficiency of von Willebrand factor will prevent platelet adhesion following endothelial injury. It will also not allow deficiency of von Willebrand factor will also not allow factor 8 to function properly. So that's why you have a bleeding problem following von Willebrand factor deficiency. Okay, so this is another illustration of von Willebrand disease. Von Willebrand factor is in fact present in the endothelial cells of the blood vessel, also in the platelets. Okay, so secreted from both sides, and it binds to factor 8 and helps in coagulation. There is an important enzyme here, as you can see, Adams 13. Von Willebrand factors are large molecules. Adams 13 is an enzyme which helps keep the size of the von Willebrand factors small. Otherwise, there will be big clumps forming in the blood vessels, clotting the vessels. So presence of this enzyme is very important, and deficiency of enzyme leads to another disease called TTP. We'll be learning about it later. TTP. Okay, so keep this in mind. We'll study about this enzyme deficiency when we talk about TTP. So at the moment, we are talking about von Willebrand disease. So as we have seen, von Willebrand factor has an important role in coagulation. So either there is a total deficiency of von Willebrand factor, or there may be sufficient von Willebrand factor but may be dysfunctional. So there are many subtypes of von Willebrand disease. We don't need to know all of them. Type 1 is the most common, where the von Willebrand factor is reduced. Okay, so we don't need to know the other types because they are rare and not important. Type 1 is the most common type of von Willebrand disease. So how do these patients present? Usually they present with mucocutaneous bleeding, that is epistaxis, gum bleeding, skin bleeding, easy bruising. Okay. In females, presence of menorrhagia is very common. And you can also have prolonged bleeding from the mouth. These are the common presentations of von Willebrand disease. Musculoskeletal bleeding like hemophilia is not very common in von Willebrand disease. Post-operative bleeding, immediate bleeding after trauma. So presentation with easy bruising and skin bleeding is much more common. So you have, so how do you come to a diagnosis of von Willebrand disease? Patient will have a normal platelet count, obviously. Prothrombin time will be normal. APTT may be normal, may be mildly raised. This is the catch point. If you have a grossly elevated APTT, that will point to hemophilia. If it's just mildly prolonged, the normal level is 25 to 35 seconds. If it's just 40, 45, think of von Willebrand disease. If it's highly raised, 60, 65, 75, look at your case, it's probably hemophilia. The bleeding time will be prolonged because it leads to impaired platelet adhesion aggregation, as I said. So it prolongs the bleeding time, which is not seen in hemophilia. So these are the points to differentiate von Willebrand disease from hemophilia. And to confirm the diagnosis, a ristocetin cofactor assay is used, which helps to measure the von Willebrand activity. Okay, so ristocetin cofactor assay is confirmatory test for von Willebrand disease. Ristocetin is an antibiotic which is used in this test, and it mixed with the blood of von Willebrand disease factor, the platelets fail to aggregate. So just remember the name ristocetin cofactor assay. This is confirmatory for von Willebrand disease. Look for a family history of bleeding. It will help you diagnose. As I said, bleeding time will be high. APTT will be just raised. Okay, platelet count, prothrombin time will be normal. Ristocetin cofactor assay is diagnostic. Okay, so remember these points because these will be the points that will help you diagnose your case. So if you have mild bleeding, you can use tranexamic acid, but the question that is commonly asked and most important is what is the treatment of choice of von Willebrand disease? It is desmopressin, DDAVP. It helps release of von Willebrand factors from the endothelial cells. So DDVAP, DDAVP is the treatment of choice. Von Willebrand factor concentrate is a second line treatment. So first line is DDAVP. Okay. In women with menorrhagia, OCPs can be used. So this is a very common and favorite question of in part 1. What is the treatment of choice of von Willebrand disease? Okay, if we go through the differences between hemophilia and von Willebrand disease, what are the important points that I told you? Number 1 is the inheritance, mode of inheritance. These are X-linked. This is autosomal dominant. Muscle joint bleeding is common. Mucous membrane bleeding is more common. Bleeding time will be prolonged in von Willebrand disease. Activated partial thromboplastin time will be normal or slightly raised in von Willebrand, much more prolonged in hemophilia. Okay, so these are the important differentiating points. These are the common questions, where the questions are asked about hemophilia and von Willebrand, giving different combinations of the lab results. So let me just give you throw a case to you. If a 17-year-old male comes to you with bleeding after tooth extraction, prolonged bleeding, or having a right knee hemarthrosis after mild trauma, platelets are normal, prothrombin time is normal, the APTT is very high. It's supposed to be within 35, it's 76. The factor 8 level was measured and it's normal. So what do you suggest the diagnosis would be?
Factor 9. Hemophilia B.
Exactly. Hemophilia B. So this is how you come to your diagnosis. That's good. Okay. Okay. So let's move on to platelet disorders. Thrombocytopenia is a common condition. I just put you a chart with some common causes of thrombocytopenia. Make sure to go through the causes of thrombocytopenia. But the important conditions that you need to know regarding platelet disorders are ITP, TTP, essential thrombocythemia, and thrombocytosis. These 4 conditions you need to know. So let's start with ITP. As you all know, it's an immune-mediated reduction in platelet count. So against what structure the autoantibody is forming? It's against the 2B3A glycoprotein on the platelets. This is a very important receptor on the platelets. The antibodies in ITP are against the 2B3A receptors on the platelets. This is a very commonly asked question. 1B is a less common antibody, but 2B3 is more common. Okay, these antibodies are usually formed after a viral infection, after vaccinations, maybe in other autoimmune disorders like SLE. You get autoantibodies forming against these complexes, leading to destruction of the platelets. So diagnosis is usually incidental. Patients are usually asymptomatic. They may have a history of fever or a vaccine or some other autoimmune disease. In some cases, they present with purpuric rash, petechiae, sometimes gum bleeding, epistaxis. Catastrophic bleeding is very rare. It's very unlikely, but not impossible. But usually you will get cases with just mild bleeding, skin bleeding or gum bleeding, so and so. Children usually have acute presentations, and the ITP in adults is usually chronic. So you will be given a case with a low platelet count, and usually these patients do not have fever or any organomegaly, just isolated thrombocytopenia. And you have antiplatelet antibodies positive, bone marrow shows megakaryocytes. And the most favorite question that is asked from this topic is the first line treatment. Oral prednisolone, and oral prednisolone is the first line treatment of ITP. Unless you have an emergency, you give oral prednisolone. This is the first line treatment. If the patient is using this steroid for 3 months, is not responding or is steroid dependent, then you move on to other treatments. You go for splenectomy, you go for immunosuppressive drugs, rituximab, thrombopoietin stimulating agents. They're all second line options. First line is oral prednisolone, oral prednisolone. This is a very important question in the exam. Usually we follow this type of protocol for patients with ITP. So obviously, if we start treatment, we start with oral prednisolone. Unless you have life-threatening bleeding, organ-threatening bleeding, and emergency surgery, you use the other options first, like platelet transfusion, IV methylprednisolone, IVIG, if you have these conditions. Otherwise, the treatment of choice is oral prednisolone. So I've just mentioned these conditions where you might get confused in the exam. You might get confused between ITP, von Willebrand disease, TTP, DIC, henoxolin purpura, hemolytic uremic syndrome. They're very close. They present very closely. So as we go on, we'll learn how to differentiate these conditions. Okay, so the opposite of thrombocytopenia, when you have a very high platelet count, more than 4.5 lakhs, 4.415 to 10 power 9, thrombocytosis. Okay, so thrombocytosis itself has a vast number of causes. Very commonly, it's reactive. After a severe infection, after surgery, any inflammatory condition like rheumatoid arthritis, inflammatory bowel disease, you may have a reactive rise in the platelet count. Iron deficiency, presence of any malignancy, there are drugs like steroids that can raise the platelet count. But we are concerned with myeloproliferative conditions. For us, the disease of concern is essential thrombocytosis. This is important for your exam. It's a part of myeloproliferative disorders, that is CML, polycythemia rubra, myelofibrosis, essential thrombocytosis. These four together constitute myeloproliferative disorders as a part of bone marrow disorders. So we'll go into essential thrombocytosis. Let me show you what questions are usually asked from here. Your patient will be usually an elderly patient, 50 to 70 years. Usually they may be asymptomatic, but commonly they will have this tingling or burning in the hands and feet. Burning sensation in the hands is very common. This is called erythromelalgia, burning pain, warmth, redness of the extremities, probably because of the raised platelets causing clumps and blocking the small vessels in the extremities. You may have sweating, low-grade fever, non-specific symptoms, splenomegaly in 40–50% cases, but these are the typical symptoms that you usually will be getting in the exam. So when you do a platelet count, you will find that the platelets are very high, usually above 6 lakhs. You may get, because it's a myeloproliferative disorder, you may have associated raised RBC, WBC. So don't get worried about that. This platelet count will give you the diagnosis. But how do you diagnose it? Is it thrombocytosis or is it essential thrombocythemia? How do you come to the diagnosis? As we know, it's a myeloproliferative disorder. Some genetic abnormalities have been found. And this is a very important question. What is the major genetic mutation that we see in essential thrombocytopenia? It's JAK2. Very important. Recently, we have had this question that JAK2 is negative. What other genetic mutation you will search for? It's calreticulin. Even this question has come once, that these two are negative. What other genetic mutation has been seen in essential thrombocytopenia? It's MPL, myeloproliferative leukemia virus oncogene. So you need to know all three names. This has come in exams recently. Okay. So what are the genes where the mutations are occurring in essential thrombocythemia? JAK2, CALR, and MPL. You have to remember these names. So once you diagnose essential thrombocytosis, first thing is you put the patient on aspirin. You have to reduce the platelets. If there is high risk of thrombosis, patient is above 60, he has a previous history of thrombosis, platelets are more than 1500, first line treatment, drug of choice is hydroxyurea. Very important question, commonly asked. Some European countries are using interferon alpha in younger patients as a first line drug, but for us, we will be using hydroxyurea as a first line treatment. Interferon alpha is a second option, especially in the older patients, and it also can be used in pregnancy. So aspirin plus hydroxyurea, treatment of essential thrombocytosis. Very important question. Now let's come to another interesting, not very common, but very interesting condition. This condition is called thrombotic thrombocytopenia purpura. Thrombotic thrombocytopenic purpura. Basically, I told you earlier, there is an enzyme called ADAMS13. The normal function of this enzyme is when von Willebrand factors and platelets start forming large, small, so that they don't clog the vessels. When this enzyme is deficient, when ADAMS13 enzyme is deficient, look at what happens. The blood vessel gets clogged with large molecules and clumps of von Willebrand factor and platelets. It blocks the vessels, leading to organ ischemia, which is the basic pathogenesis of TTP. So as a result, you have a pentad of symptoms, classical pentad of fever, thrombocytopenia, clogging clots causing thrombocytopenia, and the RBCs, as they pass through the clogged vessels, they get hemolyzed. This is called microangiopathic hemolytic anemia. And you get typically broken RBCs called schistocytes. So this classical pentad of fever, anemia, thrombocytopenia, renal failure, and patient will be confused. In your case, you will get a patient with fever, low platelet count, anemia, high creatinine, and having some sort of neurological features like confusion, seizure, or something. That will help you diagnose TTP. So classic pentad of symptoms. To differentiate TTP from other conditions, this is the catch point. You will have neurological signs. Okay. And remember, plasma exchange is the first line therapy of TTP. Very important questions. This pentad of symptoms, deficiency of ADAMS13, use of plasma exchange as a first line treatment of TTP. These are the common questions asked from TTP. Very important. Usually post-infections, most commonly leading to breakdown of the ADAMS enzyme due to some probably antibodies formed against the ADAMS13. So post-infectious is very common. So you will have a patient with a history of some sort of infection. Drugs, not very common. Tumors, SLE, but infectious, post-infectious TTP is the most common cause of TTP, leading to deficiency of the ADAMS13 enzyme. So typically the patients are adult females having these 5 features: fever, neurological signs, microangiopathic hemolytic anemia, renal failure, thrombocytopenia. So how do you determine whether the hemolytic anemia is microangiopathic? You will have fragmented RBCs in the blood film. Schistocytes is the most common. Broken RBCs. Okay. What we need? Steroids,
Excuse me,
immunosuppressants may be
sir.
used later, but first line is plasma
Excuse me.
exchange. Yeah. Sorry, somebody wanted to say something?
In TTP, there is anemia. Is it due to microangiopathy or autoimmune related?
Sorry, just give me a minute. I'll be back. Just a minute.
What's the reason of this anemia in TTP? I'm not clear about that. Just back of the slide. I can't hear you, sir.
Yes, please ask your question.
In TTP, there is anemia,
Yes,
and you have written this microangiopathy, hemolytic anemia.
yes.
What's the reason behind? What's the mechanism of causing this anemia? I'm not clear about that.
Okay. Uh, when you have these big clots in the small vessels, that's why it's called microangiopathy. The RBCs, the vessels are not fully clogged, they're half clogged. So when the RBCs are passing through the half clogged vessels, they get shredded because the clots contain fibrins. So these threads, they shred the RBCs, fragment the RBCs. So that's why it's called microangiopathic hemolytic anemia. It's a mechanical hemolytic anemia.
Okay, it's the RBC passing through the narrow lumen of the
The
vessels.
narrow clotted
Um,
lumens,
I'm
they
getting
squeeze through
trauma,
them, they come out through the other side,
traumatized.
broken and fragmented. That's why microangiopathic
Getting
hemolytic.
fractured and then remodeled. Okay, thank you, sir.
Yeah, this type of phenomenon is also seen in DIC, as we'll see later.
Yeah,
So microangiopathic hemolytic anemia occurs in a
okay.
number of conditions. Most commonly, you need to remember TTP, DIC, and HUS. In all three, by the same mechanism, there is mechanical fragmentation of the RBCs when they pass through the narrow vessels. That's why it's called microangiopathic hemolytic anemia.
Okay, okay, sir. Thank you.
Okay. So you remember plasma exchange. This is the first line treatment of TTP, and the rest of the drugs, steroids, immunosuppressants, you may use later, not commonly asked. So this is a type of scenario that is commonly asked in the exam. Very favorite question for the examiners. Fever, thrombocytopenia, high creatinine, confusion. Okay, you will have all these clues. You need to come to a diagnosis of TTP. So let's come to another very interesting condition, very devastating condition. It's DIC. Usually following some severe infection or sepsis, what happens is that the coagulation cascade gets activated. The coagulation pathway gets activated and a lot of clots are formed throughout the body. This leads to platelet consumption. The clots, they consume the platelets, they consume all the clotting factors. A lot of fibrin is generated. A lot of thrombus is formed in multiple vessels. And as the platelets are consumed, there is a thrombocytopenia. All the clotting factors are consumed within the clots, and this leads to bleeding. So this combination, unique combination of thrombosis and bleeding is called disseminated intravascular coagulation. So you have a combination of microvascular thrombi and bleeding. So if you look at this combination of events that occur, you have low platelets because platelets are consumed in the clots. All the clotting factors are consumed, involving both the intrinsic and extrinsic factors. So both PT and APTT will be raised. D-dimer FDPs are raised because all the fibrins are broken. So the fibrin degradation products will be raised. And as usual, you will also have a microangiopathic hemolytic anemia, the same way I described earlier, because of the microvascular thrombosis breaking the RBCs. So this case of an infection, starting with an infection, later progressing to bleeding and thrombosis, where investigations reveal a thrombocytopenia, raised PTA-PTT, raised D-dimer FDPs, and presence of cystocytes. This will lead to your diagnosis of DIC. This is how your cases will be given.
Sir, can you show the previous slide
Sure.
once?
This is a very complicated mechanism, so I put the pathogenesis in from different angles for you to understand.
Yeah. Coagulation.
This picture is from Kumar and Clark.
Coagulation path.
It's pretty much self-explanatory. I have some more flow charts to show you ahead to make you understand the DIC mechanism. If you're finished with this, I can go ahead.
Yes, sir.
Okay. So this is another way of looking at it. So what causes this coagulation cascade to go off like this? It's almost a series of events. Some underlying disorder activates the coagulation cascade. We'll look at these underlying disorders later. Okay, so you have blood clots, the clotting factors get used up, the platelets get used up within the clots, and there is bleeding. Okay, so you don't need to remember the details of the pathogenesis, but remembering it helps you to understand why you have a low platelet count, why your PT-APTT both raised, why your FDP is raised, why you have cystocytes. So it helps you to remember that. Okay, so this tissue factor that's released from this severe tissue injury, it starts the coagulation cascade. These are different angles of looking at DIC. You don't need to go through all of them. The same thing I've put in different pictures. So these are the important causes of DIC that triggers DIC. Most important is sepsis or any severe infection. Okay. And in your MRCP exams, this is another angle of putting a DIC case. They will put some sort of obstetric complication followed by bleeding and having those lab readings that we just saw. It can also be a case of pancreatitis, can also be a case of malignancy. So you will have a case or a background of these conditions followed by bleeding, and then you will have those lab results. Will help you diagnose DIC. Okay, so you look at the investigation profiles. As I told you, what you have to remember, your platelet count will be low. You will have a raised PT-APTT. Your fibrinogen will be low because all the fibrinogen is broken. FDPs will be high, D-dimer will be high, and you will have schistocytes because of microangiopathic hemolytic anemia, red cell fragments. So this combination of lab results will help you to come to the diagnosis of DIC. This is a very commonly asked question in the exam, very favorite for the examiners, DIC. So you have to, usual presentation or the usual scenario is the acute DIC where you have profuse bleeding. So you have to replace the clotting factors by a cryoprecipitate or fresh frozen plasma. Sometimes you need plasma platelet transfusion as well. Okay. So just treatment of the underlying cause is the main treatment with supplementation of these clotting factors by these blood products, fresh frozen plasma, cryoprecipitate, or platelet transfusion. But you need to treat the underlying cause very aggressively. Okay, I'll show you some common differences just to help you clear some confusions. For example, I told you TTP and HUS, very close. Both of them have thrombocytopenia and hemolytic anemia. So how do you differentiate? As I said, TTP has pentad of symptoms, five combination of 5 things. In HUS, usually have diarrhea followed by renal failure, hemolytic anemia, thrombocytopenia. Renal failure is more prominent here. The neurological features is more prominent in TTP. Okay, and these are HUS is children, TTP is adults. So you can differentiate it much more easily. So the renal manifestations more common in HUS, neurological manifestations more common in TTP. TTP are adults, HUS predominantly in children. Okay, very important table. ITP, TTP, DIC. You have gone through all the 3
Previous
conditions.
slide.
Sorry?
Can you show the previous slide once?
Sure, sure.
Okay, thank you.
Okay. ITP, TTP, DIC. You may get confused from your case, which is which. Let's look at the differences and summarize what we have learned so far. ITP patients are very stable, minimal symptoms. TTP, DIC patients will be very toxic. Microangiopathic hemolytic anemia, cystocytes. Only TTP, DIC, never in ITP. Both prothrombin time APTP raised, DIC. Normal, usually normal in both of them. Fibrinogen levels reduced. FDP, fibrin degradation products increased. D-dimer increased. Treatment of choice, oral steroid, ITP. Plasma exchange, TTP. DIC, supportive therapy, treatment of underlying cause. I hope you're all clear with these 3 conditions so far. So don't confuse your cases. All of them will be having thrombocytopenia, but you'll have to differentiate from the rest of the scenarios. It's the same thing looking at another way. Okay, so let's move on to polycythemia. I'll be just talking about one RBC disorder, polycythemia. Our main topic of interest is polycythemia rubra vera, which is the primary polycythemia. But polycythemia or erythrocytosis is not only this. It actually involves, the whole thing is divided into 2 groups. One is relative polycythemia, other is true polycythemia. This is not true because RBC mass is actually not increased. It's actually the plasma volume is reduced due to dehydration, diarrhea, burns, so and so. True polycythemia, you have an increased RBC mass. As a part of myeloproliferative disorder, polycythemia rubra vera is the primary cause, but polycythemia may be secondary to underlying disorders like renal cell carcinoma, HCC, COPD. Commonly, as we know, you have COPD patients having polycythemia and also people living in high altitude. So just go through the causes of polycythemia. You'll have to keep this in mind when you deal with polycythemia cases. Any cause of polycythemia may have features of hyperviscosity, because the blood is hyperviscous due to the raised hemoglobin levels. You have patients being dizzy, having tinnitus, headache, blurred vision, Pruritus is a very interesting clue for polycythemia patients. You may have ophthalmological changes because of the hyperviscous retinal vessels, neurological findings, face is plethoric. These are common features of polycythemia. Now let's discuss polycythemia rubra vera. It is a bone marrow disorder, myeloproliferative disorder. Very important to know that mutation in the JAK2 gene is responsible for polycythemia. Where did we hear about this earlier? Essential thrombocythemia. So you have JAK2 mutation also in polycythemia rubra vera. It increases tyrosine kinase activity, leading to increased erythropoietin activity and rise in hemoglobin. So you must remember the JAK2 mutation. You will have symptoms of hyperviscosity as we discussed earlier. You will have pruritus, you will have splenomegaly. This is not seen in secondary polycythemia. It's only seen in primary polycythemia. Plethoric appearance, hypertensive patients may even have bleeding manifestations. How do you investigate polycythemia? You need to look at the raised hematocrit level that will diagnose polycythemia. Very important is JAK2 mutation. This is the diagnosis of primary polycythemia or polycythemia rubra vera. However, not 100% JAK2 mutation is found. It may be negative. In that case, the diagnostic criteria is a bit different, but that is very complicated and you don't need to know the details of that. Just remember that JAK2 mutation is needed to diagnose polycythemia rubra vera. Important investigations include red cell mass to differentiate relative polycythemia from true polycythemia, and serum erythropoietin level to differentiate primary polycythemia from secondary polycythemia. And you need to look for secondary causes as well in any case of polycythemia. So this is the diagnostic criteria for JAK2 negative polycythemia rubra vera, but you don't need to remember so much details. It's not needed. Patients usually need aspirin because of associated thrombocytosis, but the treatment of choice, first line choice of treatment is venesection. You need to let out blood once every week. 400 to 500 ml of blood is usually let out every week to achieve a target of hematocrit less than 45%. Please remember these points. First line treatment, venesection, target hematocrit less than 45%. Drugs that are used, hydroxyurea, ruxolitinib is a JAK2 inhibitor. It is more commonly used in myelofibrosis, may be used in some cases of polycythemia rubra. Usually not asked, but it's written in Kumar and Clark, so you can remember the name. But important, venesection, target hematocrit, use of hydroxyurea, very important. A very, very important question asked is the prognosis of polycythemia rubra. For some reason, it's a very favorite question. Polycythemia rubra vera patients can progress to myelofibrosis. Polycythemia rubra vera patients can progress to acute myeloid leukemia. Very favorite question in MRCP part 1. Please remember these two conditions. Myelofibrosis, acute myeloid leukemia. So we'll end here for today. What I basically covered today are the coagulation disorders, that is hemophilia, von Willebrand disease. I have covered platelet disorders with you, ITP, TTP, essential thrombocythemia. We have gone through DIC, we have gone through polycythemia rubra vera. Okay. not very tough topics, but a bit tricky. So you need to go through them and remember these points that I mentioned you today. And I have tried to point out to you the common questions and the common information that have been asked recently in the exams. So if you have any questions, we can go through them today.
Sir, excuse me.
Yes, please, you can go on.
Sir, can you once discuss about this coagulation steps and the
Sure.
importance of this? Some of the medicines we use generally to prevent coagulations. Ah, eh, just because we are not clear about that, how to use which medicines to prevent the coagulation in case of heart
Okay.
disease or
Okay.
HBG
Are you talking about
and some other.
thrombosis and all that?
Yeah, coagulation
Anticoagulants? And okay.
steps and
Yes. Okay.
in respect of that, these medications to prevent the coagulation.
Okay. We have a topic on DVT in the next class. I will talk about anticoagulants and antiplatelet drugs, how to prevent thrombosis in details. For today,
Because
what was
in
relevant?
front of this coagulation cascade.
Yeah, this is the coagulation cascade, this one.
Yes, sir. Yes, sir.
For example, let me tell you two or three things. Warfarin acts through the extrinsic pathway. It inhibits vitamin K dependent clotting factors, especially 7.
Okay.
So extrinsic pathway is blocked by warfarin. So that's why, and we know extrinsic pathway function is measured by prothrombin time. That's why this is how warfarin acts, and this is why we monitor prothrombin time in a patient taking warfarin.
Okay.
Heparin, on the other hand, it blocks the intrinsic pathway, the heparin. It
Right.
blocks these 12, 9, 8, 11. So heparin acts through the intrinsic pathway. Okay, so that's why when you are giving heparin to a patient, you monitor the APTT. So this is why
Okay, sir.
PT is used in warfarin monitoring, APTT is used in heparin monitoring. So
Okay.
that's the basics of the common anticoagulants used. And this is how we use the knowledge of the extrinsic intrinsic pathway.
The
Like I
antiplatelet,
said,
the
like
APT.
like in hemophilia. In hemophilia, we have factor 8 deficiency. So you have the intrinsic pathway that is disturbed due to factor 8 deficiency and hemophilia. That's why the APTT is raised in hemophilia, not prothrombin time. Okay?
Right, sir. Thank you, sir.
So the mechanism of action of some oral anticoagulants, that's always asked, right?
Yeah, I'll discuss that with DBT. I gave you example of warfarin. The other newer anticoagulants like rivaroxaban, apixaban, they act through factor 10, sorry. They are factor 10 inhibitors. So they are monitored through both prothrombin time APTT. So we'll discuss
So
the
for
drugs little later. Yeah, in the next class.
okay.
The DVT and
Okay.
anticoagulants we'll discuss in the next class. Anything else from today's topics? I hope you able to catch the important points that I mentioned, the common questions that are asked.
Yes, sir.
So I hope you solve questions, some questions from earlier years, and you go through these topics. I hope you'll find that most of the questions are covered through the information that I have given you today. There's a lot of information in hematology, but
Sir,
please go through the specifics that I've given you today. Yeah, please go on.
sir, regarding ITP, this
ITP.
is
Yeah,
autoimmune disease.
yeah.
This autoimmune. This etiology is autoimmune. And can you explain about which infections or what is the condition that triggers to that autoimmune conditions to
Yes,
leads
yes.
towards ITP?
Yeah. Yeah, commonly viral infections, as I've shown you in this slide. This is very common that following a viral infection, especially in children, after a fever, even in adults, the platelet count stays low and does not rise. After certain vaccines, these are the two most common backgrounds that have been seen. Infection with any sort of virus, any sort of vaccine, presence of other autoimmune disorders, especially SLE. Having SLE will lead to
Okay.
developing antibodies against platelets also, even malignancies. So presence of viral infections and post-vaccination. ITP is
Okay,
very
sir.
common. These are common etiologies. And you must remember that the antibodies is against the 2B3A receptor on the platelets. This is the important question that's asked.
Is it self-limiting disease or is it
It's not
different?
self-remitting, unfortunately. In some cases, it can be self-remitting, where without any drug, just by observing, it sometimes remits. I will show you the slide. Especially in children in acute ITP, you can see I have written here. In children with acute presentation, sometimes it may have a self-remitting course, but very unpredictable. You'll have to follow up. In chronic ITP in adults, it's usually a relapsing remitting course. This is usual, but there can be variations.
Ivan syndrome.
And remember to answer first line treatment, oral prednisolone in ITP, unless you have other situations.
Okay, sir. Thank you.